Good afternoon, dear colleagues. I would like to welcome you all to this plenary session 2 of the 32nd International Congress of Antimicrobial Chemotherapy. My name is Dr. Ünal, Serhat Ünal. I work in the University Hospital, Hacettepe University, Ankara, Turkey. And I'm very happy to be here and to chair this session. The lecturer, Dr. Juan-Pablo Horcajada, is a very experienced name about this. He is the Chief of Department of Infectious Disease and the Infection Control Coordinator at Hospital Del Mar, Barcelona, Spain. Professor of the Department of Medicine and the Life Sciences at University of Pompeu, Fabra of Barcelona. His field of research is about optimizing the use of antibiotic and applying PK/PD data for the treatment of the difficult-to-treat infections, including healthcare-associated and the infections due to multidrug resistance microorganism, especially extremely drug-resistant Pseudomonas aeruginosa. He has published more than 300 scientific articles and has directed several competitive research projects as a principal investigator and doctoral thesis. He participates in several international clinical trials with antimicrobials. He is the Spanish delegate and a member of the steering committee of the European Committee for Infection Control of the European Society of Clinical Microbiology and Infectious Diseases. And how lucky we are, currently he is a visiting professor academic at the University of Queensland Center for Clinical Research. Please, Professor Horcajada.
Thank you. Thank you so much. It's a pleasure to be here. Barcelona is so far away, but now in Queensland, I understand more how you live here, so it's fantastic. So we are going to talk about the treatment of multidrug-resistant Pseudomonas aeruginosa infections. These are my disclosures. First of all, we're going to talk about the importance on frequency of multidrug-resistant Pseudomonas aeruginosa infections. We're going to talk about the high-risk clones, which is a concept that's important to have in mind with Pseudomonas aeruginosa, because they are associated with mechanisms of resistance. We will talk about the treatment with colistin. We had pretty experience of treatment of these infections with colistin before the arrival of the new antimicrobials. We are going to talk about also how we apply the hollow fiber model in these infections, which are the current antimicrobial options. So why is Pseudomonas aeruginosa? Pseudomonas aeruginosa is the second. Pseudomonas aeruginosa is the second in a list, in a worry, concerning list published by the World Health Organization, in which the first one is Acinetobacter baumannii, and the second one is carbapenem-resistant Pseudomonas aeruginosa. And these are based on different factors like treatability, mortality, associated mortality, or associated with trend of resistance, if it's going to increase or not. It's based on the transmissibility. It's based on, for example, it's based also in which options will be for new antimicrobials, and all these factors give this rank of priority of multidrug-resistant bacteria. And it is also clinically important because it's one of the most frequent causes of severe nosocomial infections, especially Pseudomonas pneumonia and bacteremia, which are very, very severe. Particularly affects ICU and immunocompromised patients, which are also more in a higher risk of mortality. It is the first cause of VAP and burn infections. It's associated with very high mortality rates, as I said before. Most frequent driver of chronic respiratory infections in cystic fibrosis or other chronic diseases. And it has extraordinary capacity of developing resistance. And this is why we are studying this microorganism. It is associated with an increased mortality. It's demonstrated in different studies. This is a systematic review in which multidrug resistant Pseudomonas compared with non-multidrug resistant Pseudomonas has a twofold increase in the risk of mortality. So that's a lot. So the risk ratio is 2.3, having or not multidrug resistant Pseudomonas aeruginosa infection. So we are talking about a huge problem, and we demonstrated that directed therapy improves surveillance, appropriate definitive antibiotic therapy is a protector factor against mortality. So we need therapy we need new therapies, like, for example, phage therapy, that was talked before here in a symposium, because we don't have many antimicrobials for this. And the percentage of resistance of ceftazidime or meropenem around the world is higher than 20% in a lot of countries. You can see the Western Europe, you can see also the Eastern Europe, you can see Asia, Latin America, no country without problems. Maybe the north of Europe and Canada and Australia, they have less cases, but it is a huge problem all around the world. And this Pseudomonas aeruginosa spreads around the world by means of these high-risk clones. High-risk clones are a definition of special clones that they are prone to have more resistance, they are more easy to transmit, they have a very high level of resistance, they have multiple mechanisms of resistance, and they persist. They persist in the environment, and they get endemic in a lot of countries. In my hospital, we have an endemic situation of one clone, which is the ST175. Here in Australia is the ST235. The ST235 is the most virulent of all of them. There are a lot of them. The three most frequent are the ST235, which is present in Australia, the ST111, which is present in some countries in Europe and also in Asia, and the ST175, which I talked before, is also present in Europe. In our case, in order to have an example of what we are talking about, the ST175 clone, which is less virulent, it's true, it's less virulent, but it has a lot of mechanisms of resistance together. We are not talking about the MEC-A, like we talked before, with one mutation in one gene. We are talking about mutations that compromise aminoglycoside resistance because there is a permeability alteration and because there are efflux pumps that permit that aminoglycosides are got out from the cell. Beta-lactamic resistance is driven by chromosomal AMC hyperproduction, efflux pumps, and porine mutations, and also type 1 and 2 OXA enzymes, quinolone resistance by GRA topoisomerase mutations and permeability alterations, and carbapenem resistance also driven by porins and efflux pumps, and AMC also. So this is a machine. This is a very difficult to treat. Because of this, Pseudomonas aeruginosa frequently is extremely drug resistant or even pan-drug resistant to all antibiotics. Because of this, in our hospital, in which we had an endemicity of ST175, we started to use colistin because we didn't have anything. These antimicrobial resistant mechanisms give the phenotype of only susceptible to colistin and sometimes susceptible to amikacin. So we only could use colistin for treating these infections. And the mortality rate was very high, 37% in case of bacteremia, 35% in case of pneumonia. So colistin even if it's bactericidal, in our experience, the mortality rates were too high. In fact, if we take a look at the literature and we compare colistin with other comparators, if it can be compared, in most of the studies when colistin is compared with another drug, the studies demonstrate or they favor the comparator. Colistin gets always the second, gets always back when you compare it with comparators. And we were asking us why this bactericidal drug is not as efficient as we would like. So we started to do studies with PK studies with colistin, and then we measured the throughput levels or the steady state levels, because you know that colistin at the beginning, it needs like 2-3 days to have a steady state situation if you don't give a loading dose, which is as we used before the consensus of colistin use. But when you are in the steady state, we saw that patients with nephrotoxicity had 3 times the levels of patients with no nephrotoxicity. So we were talking about 3 milligrams per milliliter in patients with nephrotoxicity in comparison with 1. Okay? And this was this breakpoint. We calculated a breakpoint of 2.4 at the end of treatment, was a predictor factor of nephrotoxicity more potent, stronger than the H or the Charles index or the total days of colistin or the total dose. So it was a strong predictor of nephrotoxicity, the level of colistin in blood. And we validated this cutoff point of 2.4 in a prospective cohort, and we demonstrated also in the multivariate analysis that this cutoff was the only predictive factor of nephrotoxicity in comparison with other factors. So knowing that the MIC that we need to reach with colistin for Pseudomonas aeruginosa is 2, we have a very narrow therapeutic window. This product, this drug, has a very narrow therapeutic window because you have to arrive to 2. But if you arrive to 2.5, then the patient could have nephrotoxicity. So we think that is part of the reasons that this drug is not so efficient. In fact, we tried to analyze if the levels of colistin were also easy to predict, were predictable of clinical efficiency or clinical efficacy. And then we saw that patients that did had higher levels. Here we have 2 against 1.4 in the steady state milligrams per liter. But what we were seeing, patients that did had a higher nephrotoxicity rate, 50% at day 7, 71% at the end of treatment, in comparison with those patients that were alive, which also had some nephrotoxicity, but not so high numbers. And then we also performed a multivariate analysis of this cohort of patients treated with colistin. And apart from the severity of the patient and the conditions of the patients, which were also risk factors for mortality, the renal failure, patients with renal failure had a higher, like 3.8 times odds ratio of dying. So what we discovered is that colistin could also have this bad influence for patients and be a risk factor for mortality. Then we need new drugs. We need new drugs. Ceftolozane tazobactam is one of the best anti-pseudomonals that we have today. Ceftolozane itself has a high affinity for PVPs, especially for PVP3, which is very present in Pseudomonas aeruginosa, and PVP1b and 1c, which is also present in Pseudomonas aeruginosa. It has higher stability against AMP-type beta-lactamases, which is one of the most frequent mechanisms for resistance in Pseudomonas aeruginosa. It overcomes the effect of ejector pumps and pouring mutations, so it's a good tool against Pseudomonas aeruginosa. It has a greater activity against Pseudomonas aeruginosa in comparison with previous anti-pseudomonals. Also, tazobactam inhibits beta-lactamases and ESBLs, but this is nothing to do with Pseudomonas. It's because the spectrum, they wanted to be wider, but the drug that acts against Pseudomonas is ceftolozane. Clinical data, we don't have so many clinical data, especially we don't have comparative data. This is a sub-analysis of the ASPECT MP clinical trial comparing ceftolozane tazobactam versus meropenem for treatment of nosocomial pneumonia, in which the results in Pseudomonas aeruginosa and in multidrug-resistant Pseudomonas aeruginosa were similar. I don't know if we have.
Point out there.
Yeah, but it doesn't work. No problem. So if we need more data, we can review the clinical experience, especially in observational study. This is a publication from Israel, in which they describe 12 studies. And what was very useful for comparing in our previous series with colistin is that multidrug-resistant mortality was 20% in these 12 studies. 20% compared with 35, 37% that we had with colistin. I don't know if you remember. I think it's an interesting improvement. In fact, this is a comparative study that is being used by the European Society for establishing ceftolozane tazobactam as the first choice for treating these infections. Even if it's a retrospective, it's comparative, and it compares 200 patients, 100 per arm, most of them very severe patients. And what they saw is that clinical cure was 81% in ceftolozane tazobactam branch and 61% in the polymyxin aminoglycoside, because it's compared ceftolozane tazobactam compared with colistin or with polymyxin or aminoglycoside, with a significant difference. There was no clinical difference in hospital mortality, but again, we have this 20% mortality with ceftolozane tazobactam. And of course, acute kidney injury was more frequent in polymyxin treated patients with a significant difference. So we have a better antibiotic than colistin based on this study. And a very recently published, also retrospective but comparative study of ceftolozane tazobactam versus best antimicrobial therapy in pneumonia, lower respiratory tract infections due to multidrug-resistant Pseudomonas aeruginosa from the group of Ryback in the United States. And then they compare the primary outcome, which was a composite clinical failure, which was like 50% in the best alternative therapy in comparison with 23 in the ceftolozane tazobactam trial arm. 30-day mortality was not statistically significant, but they have only 15% of mortality in the ceftolozane tazobactam group, and adverse drug reactions were most frequent also in the best alternative arm. when they perform a multivariate analysis regression for factors associated with clinical failure, the treatment with ceftriaxone tazobactam was a protective factor in comparison with being in the other brand. So even if we don't have a randomized control trial that maybe will be needed in the near future, excuse me, even if we don't have a randomized control trial, these preliminary results based on retrospective studies, I think that they are very positive for these patients because these patients until now have been treated with colistin with very bad results. There is also some clinical experience with ceftriaxone tazobactam demonstrating some development of resistance. This is why I use this slide. This is a small study, it's only 21 patients, observational study. But in this study, resistance emerged in 3 patients, in 14 of the patients. The mechanism of resistance was an overexpression of AMC and mutations in the AMC omega loop of the chromosome. And this is worrisome, this is concerning, because this is a new antimicrobial, and we know that Pseudomonas aeruginosa has a very important tendency to develop resistance, even to new antimicrobials. And that's why we are studying this Pseudomonas aeruginosa, this multidrug resistant and extremely drug resistant Pseudomonas, in the hollow fiber model. The hollow fiber model, as you know, is like a cartridge with two separated compartments. Inside of these fibers, which is composed with a lot of hollow fibers, that in this hollow part, in the middle of the fibers, you can enter the antibiotic, and in the space that is between the fibers, you can have the bacteria with the nutrients of the bacteria, and then you start this process of infusing the antibiotic inside the fibers, like simulating the capillaries, and this antibiotic is going to diffuse to the extracapillary space. It's a second compartment. This is a big compartment model. And then you can simulate the human pharmacokinetics and pharmacodynamics. And with this model, we started to study different combinations of ceftriaxone tazobactam in this case. And as you can see in this figure, the use of meropenem, which is in red, had non-effect on the control on the studied bacteria, because it was the clone ST175, which is fully resistant to meropenem. Ceftriaxone tazobactam alone has an initial effect of lowering like 2 logarithms the quantity of the inoculum of bacteria, but it regrows again. This, the hollow fiber model can be performed for 7 or 14 days, so you are imitating the dynamics of a real infection. It's like if you are studying an animal model, but it's in plastic, no? But then we combined meropenem and ceftriaxone tazobactam, which is the blue line, and we show that with ceftriaxone tazobactam combined with meropenem, we had a reduction of 3 times the logarithms from 6 to 2, and it persisted in 2. So it was the most efficient combination in this model. So we started to think about that ceftriaxone tazobactam combined with meropenem, in this case, could be a future combination that could be tested in clinical trials. We also studied the combination of ceftriaxone tazobactam plus colistin. This is the chemostat model, because the hollow fiber model cannot be used for colistin because colistin is sticky and it joins to the plastics and it's difficult to work with the hollow fiber. But we use the chemostat model, which is another dynamic model. And in this dynamic model, we combine ceftriaxone tazobactam plus colistin And we saw that it was the best combination in this scheme because we used colistin alone, which is the B. We used ceftolozane tazobactam alone, which is the line with the triangle. And we used the combination, which is the last line down, and in which there was a regrowth at 12 hours, but a regrowth that was not so important that with the other combinations. So colistin combined with ceftolozane tazobactam could be another option. With the hollow fiber model, we can also study different infusion regimens because we know that beta-lactamics can be infused in intermittent infusion. It can be administered in extended infusion, or they can be administered by continuous infusion. So we used several clones, but these two clones that I put here, they naturally had an MIC of 8 against ceftolozane tazobactam, the first one, and the second one has an MIC of 16. So we are nearer the resistant MIC, which is 32. And when we used intermittent infusion, extended infusion, and continuous infusion, the red, the green, and the purple one, what we saw is that in the second strain, which is more resistant, only the continuous infusion maintained an acceptable activity. Intermittent infusion and even extended infusion in this model, they failed in comparison with continuous infusion. So what we recommend when treating severe infections due to extremely drug-resistant Pseudomonas aeruginosa infections susceptible to ceftolozane tazobactam is to use it in continuous infusion. We also compared what happens with the steady-state concentration of beta-lactams. Once we assume that we are going to use continuous infusion, then we have to talk about which is the best steady-state concentration. So when we used a steady-state concentration of 20 milligrams per liter in comparison with 45, we had a regrowth of this Pseudomonas aeruginosa. So what we think is that even if it's more difficult to achieve, the concentration of 45 in comparison with 20 prevents the development of resistance in patients. This is in the hollow fiber model. But even if 20 is acceptable in the papers or in the technical data from ceftolozane tazobactam, when we are treating extremely drug-resistant Pseudomonas aeruginosa, we need to optimize the infusion rate, and we have to optimize to have a higher CSS, a steady-state concentration. And what happens with the next antimicrobial? Ceftazimab-avibactam is also active against multidrug-resistant and extremely drug-resistant Pseudomonas aeruginosa. As you can see here, this is a series that we perform in Spain from 51 Spanish hospitals, like 1,400 strains, which we analyzed with the EUCAST criteria from 2018, the susceptibility rate of ceftolozane tazobactam and avibactam and ceftazimab-avibactam, and they were similar. They were active against 94% of the studied strains, like more or less like colistin. Both of them has the same activity. And then which data we have with ceftazimab-avibactam against Pseudomonas in clinical trials? So we can analyze the data from the REPROVE study, which is the study comparing ceftazimab-avibactam versus meropenem in nosocomial pneumonia. And the Pseudomonas aeruginosa patients have similar results with ceftazimab-avibactam and meropenem in this study. And the microbiological response was also similar in both branches. This is the sub-analysis from the REPROVE study. Of course, we are talking about 40 patients, so we don't have much data. We have data from observational studies. This is an Italian study comparing the effect of ceftazidime-avibactam in patients with Pseudomonas aeruginosa and other multidrug-resistant gram-negatives, but in this study there were 33 patients with Pseudomonas aeruginosa, in which the clinical cure was around 88%. So I think this is good news, although this is no comparative study. And we have more clinical experience with ceftazidime-avibactam. For example, this post-hoc analysis of 5 randomized controlled trials, around 1,000 patients with multidrug-resistant infections treated with ceftazidime-avibactam versus carbapenem in different trials. And we could analyze 95 patients with multidrug-resistant Pseudomonas aeruginosa, and with ceftazidime-avibactam, the clinical cure was 85%, similar to carbapenem, 87%. And microbiological responses were also similar, 57% versus 53% in carbapenems. And another study of 63 patients with multidrug-resistant Pseudomonas aeruginosa, mostly pneumonias, treated with ceftazidime-avibactam. The mortality rates were very good, because 17 is a good rate, and the clinical response was at 70%. That's more or less the data that we have with ceftazidime, clinically talking. So we need more data, we need more comparative results, because there are also mechanisms of resistance, and we have to understand if this drug can be used in monotherapy or combined or in different diffusion, because we have these efflux pumps, we have metallo-beta-lactamases in Pseudomonas aeruginosa that can act against the ceftazidime-avibactam. We have a study also, the colistin combined with ceftazidime-avibactam in Pseudomonas aeruginosa extremely drug resistant, and what we saw was that colistin combined with the ceftazidime-avibactam reverts the resistance of ceftazidime-avibactam. This is a time-kill series model. It's not a dynamic model. This is a static model. But when we compare the effect of amikacin and ceftazidime-avibactam, athronam and ceftazidime-avibactam, meropenem and ceftazidime-avibactam, and colistin, amikacin and colistin were the best combinations with ceftazidime-avibactam, but 100% of the ceftazidime-resistant strains reverted the resistance to ceftazidime-avibactam when combined with colistin. And also, we saw that the suboptimal concentrations of the ceftazidime-avibactam when it's infused in continuous infusion has also some consequences. This is a case of a patient that during the therapy of Pseudomonas pneumonia, the patient developed resistance to, the Pseudomonas aeruginosa developed resistance to ceftazidime-avibactam because the CSS concentration of ceftazidime-avibactam in continuous infusion was lower than expected, because the patient at the beginning has a renal failure, but the renal function started to improve and doctors didn't change the dose, so the CSS was lower than expected, and then there was a development of resistance. We reproduced the same scheme in the hollow fiber model, and what we saw is that ceftazidime levels were higher than 4 times the MIC. There was no development of resistance. But if the levels of ceftazidime-avibactam were 4 times lower than 4 times the MIC in continuous infusion, there was a development of resistance based on AMC mutation. In 2019, we have the honor to be invited by the American Society of Microbiology to write this review of the epidemiology and treatment of multidrug-resistant Pseudomonas aeruginosa in the clinical microbiology reviews. And when we did that review in that moments, we could divide the Pseudomonas aeruginosa in 3 important genotypes. phenotypes, excuse me. So these 3 phenotypes, the first one is susceptible only to colistin, amikacin, and ceftolozane tazobactam and ceftazimabactam, resistant to all other anti-pseudomonals. This is typical from the ST175, and this is because an AMC overexpression and OPRD deficiency. And we recommended to treat these clones with ceftolozane tazobactam or ceftazimabactam, and in severe cases, we recommended to combine them with colistin or amikacin. In the third line, because the second I will explain it later, the third line is the same, but it's only susceptible to ceftazimabactam, colistin and amikacin, because it's resistant to ceftolozane tazobactam and other anti-pseudomonals, and this is because the presence of a class A carbapenemase, such the GIS enzymes, and it is typical of the ST135, which is the more virulent and it is the more present all around the world. We recommended to treat these cases with ceftazimabactam, and in case of severity, combined with colistin or amikacin. And in the second line, we have the MBL production with metallo-beta-lactamases that makes this resistant to ceftazimabactam, resistant to ceftolozane tazobactam, susceptible to aztreonam, and then we recommended aztreonam in combination with other drugs for treating this. And this is present in ST235 and other clones, less in 175. New drugs. We have new drugs. We have imipenem relebactam. Interestingly, relebactam potentiates the activity of imipenem against carbapenem-resistant Pseudomonas aeruginosa by hyperproduction of ANTHI and loss of OPRD porine. It has no effect against metallo-beta-lactamases. And imipenem and relebactam are not substrate of efflux pumps. So even if it was designed to treat enterobacterales, carbapenem-resistant enterobacterales, because relebactam is an inhibitor of carbapenemases, except metallo-beta-lactamases, it is also a very good anti-pseudomonal. In the RESTORE-IMI-1 trial, which was carbapenem-resistant gram-negatives guided clinical trial, Pseudomonas aeruginosa was the most common, even it's not a lot of patients, but the favorable overall response at 28 days was observed in 81% with imipenem relebactam, which is good news. In the RESTORE-IMI-2 study, which is nosocomial pneumonia clinical trial, there were like 1/3 of the patients had Pseudomonas aeruginosa, and the results were not statistically significant differences between pip-tazo and imipenem relebactam, especially in the microbiological results. In real life, there has been a recent paper, retrospective study in 8 hospitals in the United States, mainly respiratory tract infections, and mainly Pseudomonas aeruginosa infections, most of them multidrug resistant. 1/3 of the cases received combination therapy, and mortality was very high, was 33%, which remembers that of the colistin. There were very severe patients, of course, and in one case there was development of resistance. So we have to be careful also with these new antimicrobials, and maybe we have to think about how to prevent the development of resistance. And the last drug is cefiderocol. Cefiderocol is a new drug that uses the iron transport system to increase the periplasmic penetration, and at the same time, it's stable against many class A, B, C, and D beta-lactamases, including metallo-beta-lactamases. So this is a very broad spectrum antimicrobial. As you can see, in all the table is green for cefiderocol. It's active against KPC, NDM, OXA48, carbapenem-resistant Pseudomonas aeruginosa, carbapenem-resistant Acinetobacter baumannii, Stenotrophomonas maltophilia. Because of these mechanisms of action, this enters in a high quantity in the periplasmic space, and it's also resistant to the effect even for metallo-beta-lactamases. So at this moment, in this multi-drug resistant era, is the antimicrobial with the broader spectrum. And their intrinsic activity against Pseudomonas aeruginosa, carbapenem resistant, is that it has the lower MICs, as you can see in the table and also in the graphic. The figure, you can see the first line is the line corresponding to cefiderocol. This cure demonstrates that the MICs are the lowest, because it's more at the left side of the cure. The credible study is the one that we have comparing cefiderocol against Pseudomonas aeruginosa and other gram-negative infections. And in the case of Pseudomonas aeruginosa, the results with cefiderocol, when the infection was not produced with Acinetobacter at the same time, because this study permitted the combination or mixed infections, the results were similar with cefiderocol and the best available therapy. So at this moment, cefiderocol could be also another good option for treating these difficult-to-treat infections. And what happened with the old antimicrobials at the same time? Because we have been treating patients also with the old antimicrobials, but patients with complicated urinary tract infections. This article, which has been published recently, we demonstrated that aminoglycosides or colistin monotherapy could be an alternative for these infections, because the levels in urine of colistin and amikacin are so high that it works in these patients without using these new antimicrobials and without special problems of toxicity in comparison with ceftolozane tazobactam and amikacin and ceftazidime-avibactam. So this comparative study, which is a prospective study based on the criteria of the clinics, but we could compare around 100 patients, we saw that complicated urinary tract infection can be treated with monotherapy, with amikacin or colistin, instead of these new antimicrobials. And this is what the guidelines are recommending, because as I resume, and this is the end of the talk, as a conclusion, we can review rapidly the guidelines, and the ISAC guideline says that cystitis and pyelonephritis could be treated with any of these new antimicrobials. They recommend ceftolozane tazobactam or ceftazidime-avibactam or imipenem-celastatin, relebactam or cefiderocol for cystitis, and colistin as a second alternative. In pyelonephritis, they recommend the same, but in infection outside of the urinary tract, they don't recommend cefiderocol, because in the credible study, cefiderocol has a higher mortality due to the Acinetobacter baumannii, but the ISA do not recommend cefiderocol outside the urinary tract as a first therapy. And what about the European guidelines? The European guidelines are more conservative, because they say that there is no clinical evidence in the literature for recommending another anti-Pseudomonas but ceftolozane tazobactam. They say that ceftolozane tazobactam, the evidence that we saw today, is enough to recommend it at the first line, but they don't recommend imipenem relebactam, nor cefiderocol, nor ceftazidime at this time, because the clinical evidence for the committee that wrote these guidelines is the evidence was not enough at this moment. And they recommend to use all antimicrobials in non-severe infections like the urinary tract infections, like we had recently published. They can't recommend for or against the use of combination therapy with this new ceftazidime-avibactam or ceftolozane tazobactam or cefiderocol, because there is no evidence. But in our experience in vitro, we demonstrate that extremely drug-resistant Pseudomonas aeruginosa is better to treat with combination therapy, but we have to see also in the clinics. No? We have to organize clinical trials to demonstrate, for example, ceftolozane tazobactam plus meropenem, as we said before. And they also recommend 2 drugs when treating severe infections with aminoglycosides or fosfomycin or polymyxins when it is not possible to reach or to use these new antimicrobials. And I think this is all. Thank you so much for your interest. This is my hospital at the beach in Barcelona. You are also welcome to see our hospital and also the city. It's a fantastic city. And here you have my data if you want some interaction or some even collaborations in the future. Thank you so much.